Hello, and thank you for joining today's webinar. We will begin in 1 minute. Hello, and thank you for joining today's webinar. We are ready to begin. Today's webinar is eligible for 1 contact hour. Sigma Theta Tau International Honor Society of Nursing is accredited as a provider of continuing nursing education by the American Nurses Credentialing Centers Commission on Accreditation. The speakers and planning committee members have disclosed no conflicts of interest. To receive contact hours for this CNE session, participants are required to attend the webcast and complete the evaluation form, which will be emailed to all attendees approximately 1 day after the webcast. This webinar is being recorded and will be available via the Sigma repository within a few business days of recording. Following the presentation, we will have time for a question and answer session. You'll see on your GoToWebinar control panel that you can send a question through the questions feature. This is where you can type in any question you'd like to pose to the presenters. Be sure to hit send so the message makes it to us. To test out this feature, please submit the state or country you are from. We would like to thank our speakers for sharing their expertise with us today. Our speakers are Dr. Amy Haddad and Dr. Leonard Ortman. Dr. Haddad served as Director of the Center for Health Policy and Ethics at Creighton University from 2004 to 2008. She taught healthcare ethics in nursing, pharmacy, and medicine programs at Creighton, as well as an online graduate program in healthcare ethics at Creighton. She received her BSN from Creighton, MSN and PhD from the University of Nebraska, and MFA from Queen's University. She is a fellow in the American Academy of Nursing. As Senior Ethics Consultant with CDC's Public Health Ethics and Strategy Unit, Dr. Leonard Ortman provides ethics training and consults for CDC staff and programs, including emergency response. Prior to the CDC, he taught ethics most recently at the Tuskegee University National Center for Bioethics. He holds degrees in philosophy from Yale and Penn State. He edited a global public health ethics casebook and currently is editing a companion volume on narrative public health ethics. We are so excited to have both of you with us today. Now let's get started with today's presentations.
Okay, this is Amy Haddad, and I'm really pleased to be on this presentation today. And I'm going to start out with the aim of my comments today are going to be to sort of set the stage for a mental model that nurses and other health professionals can sort of have with them, to carry around with them when they're confronting different issues that they construe to be ethical ones during this pandemic. So I wanted to start by talking about what ethical competence is. And I'm going to assume that nurses, physicians, and other health professionals make ethical decisions on a daily basis. It's just part of what we do in our clinical interactions with patients and colleagues and others. And all nurses, then we'll focus specifically on nurses, especially those who are in leadership roles, should be able to recognize what an ethical issue is, what the components of an ethical issue are, and next to be able to use statements from our professional associations to help guide judgments. And I would add to not only guide judgments, but to give some heft to whatever judgments and arguments that nurses then provide to others during this time. And I'm going to turn quickly to two sources of professional associations that can guide such judgments. The most recent ANA Code of Ethics affirms that nurses of course, have duties to patients and their families in the community, but Provision 5, not but, it's an and Provision 5 states the nurse owes the same duties to self as to others, including promoting health and safety. So that's something I'm going to return to several times in here, that we have obligations, even on a regular basis, we have obligations to patients and families and those we serve in that capacity. And then we have obligations or duties to ourselves and our own well-being. The International Council of Nurses, in its position statement on nurses and human rights, reinforces the obligation to safeguard, respect, and actively promote people's health and rights at all times in all places. And then this includes ensuring that adequate care is provided within the resources available, which is interesting that the International Code would very specifically point out that adequate care is provided within the resources available. So it gives it a contextual sense and in accordance with nursing ethics. It also affirms that nurses have a right to practice in a positive practice environment that provides safety. And then after recognizing ethical issues and using resources from professional associations, nurses have to be able to think critically and systematically through ethical problems and using tools of ethical analysis. And I think that that's where the focus of most of my remarks are going to be, that the tools we use may vary depending on what sort of ethical issue we're looking at what level. And then lastly, that we would provide reasoned, articulate judgments to those involved. And I'm going to add here that I don't think that this is a time for nurses to be acting all alone. I think it's a time for nurses to work with each other so that we can bring the power of the profession forward to make arguments about ethical issues that are concerning to us as individuals, but then to the profession too. Next slide, please. So when we're talking about looking at ethical issues and reasoning through them, if we think about it in regular days, not during pandemics, everything we do as individuals is generally, especially as nurses, are part of institutions, and those institutions reside in the larger society. And I'm going to use a model to show that the tools and priorities and timelines are going to differ in these different realms or contexts of ethics. And they're not separate. They're embedded, or they have relationships or interdependencies with each other. So next slide. This model is very, very simple. It was developed by Jack Glazer in 1994, and he wanted to tease out the relationships between looking at ethics on an individual level that's embedded in institutions. And institutions are not only healthcare institutions, but institutions such as religious institutions and education and government, and think of all the different institutions that comprise our lives that we're not able to be a part of right now, and then in the larger society as a whole. So when we look at the individual area of ethics, it really it's probably where most healthcare ethics work has been done in the past, is focus on individuals and autonomy of individuals and looking out for the benefit and well-being of individuals. And it's these very personal, intimate relationships in our lives that are part of this individual realm. It's a pretty simple model to hold, and so I'm going to try and tease out some things that might not be immediately apparent. We've already said that in this individual realm, nurses have a duty to care for patients, and we do this in a very intimate way. The physical proximity that nurses have with patients is part of that relationship. And that's whether nurses are in a hospital or an ambulatory setting or home care or wherever. Nurses as individuals have to hold to professional standards and accountability to individual patients with whom they interact, but they must balance these in a crisis situation when there is scarcity of equipment, medications, or colleagues. On an individual level, nurses need to be aware of and protect their own health, as I've mentioned, and safety regarding such issue as regular breaks, adequate PPE, shift rotations, and support for their well-being and information and guidance from institutions. Now, all of this seems like, well, that would be at an institutional level. It is too, But as individuals, nurses would be aware of whether or not they're getting regular breaks or have adequate protection equipment, or that their shift rotations are not killer, and that they have support in some way from their institution. And I think the two things that are important is that their own well-being, and then um, accurate and current information um, about individual issues within the institutions where they work. Next slide, please. So at the institutional level, um, we're looking at the net good of the institution and the good of individuals within the organization or institution, and then the common good. So at the institutional realm, you look within and without. That is, institutions are responsible for the individuals within their institutions, and they're responsible to society in which it resides. So employers and supervisors in institutions have a corresponding duty to reduce risks. And under this category, I would say for the people that are employed there, the individuals that are within institutions, this means proper equipment, training, nurse to patient ratios. So an article in the New York Times over the weekend about intensive care units at a hospital in Brooklyn, they were talking about the usual ratio of nurses to patients in their intensive care unit is one nurse to two patients, and they're now at one nurse to five patients. So I'm just bringing them up as a clinical example. Employers and supervisors have to plan for competing priorities that nurses are going to have. And two examples of this would be childcare, that usually comes up, but also I think a lot of nurses are involved in caring for elderly family members. So that would be another um, area that the institution would need to plan. And then address moral distress. And this has come up frequently in conversations about nurses who are in crisis level practice right now. And moral distress is the conflict between doing the right thing and not being able to do so. So you know what the right thing to do, and yet you cannot do it for some reason. But I would say that the right thing in a pandemic would likely differ from standard practice. So even defining on what the right thing to do would be, my guess is that a lot of moral distress is that nurses are still operating from an individual realm of ethics and their responsibilities to patients and haven't yet shifted to this more public health centered way of thinking about what the right thing to do is under these circumstances. Institutions need to recognize that competent staff are a key resource. They're as important as ventilators. So every time we see a proposal about how ventilators and the allocation event should be conducted, if there's not a corresponding focus on how the people who are going to be competent to take care of patients on ventilators and take care of the ventilator and the patient, I think that's short-sighted and doomed to problems, to say the least. The shift to crisis care standards has to occur on an institutional level, and it should be in collaboration with key health professionals, policymakers at the county or state level, and the community. And specifically, the shift to crisis care standards is a formal declaration by the state government. And I didn't even know that until I was preparing this. So that's something that I wanted to share with everybody, that this is not just institution by institution, it's a declaration by state government. And the collective competence of nurses is critical to planning and implementation when that sort of shift takes place in an institution. Next slide, please. I think I've kind of covered these things, but that the ethical concerns of institutions are broader than and stretch beyond the practice of just clinical care. And you can't name everybody within an institution, but it does involve a lot of people that sometimes we may overlook, beyond health professionals that we're focusing on today, but certainly patients, families, technicians, other service providers, volunteers, administration, and trustees. Next slide, please. So at the societal level, and this is the level at which Dr. Ortman is going to spend a lot of his presentation talking about. So I will just mention a few things here. So at the societal level, we're dealing with the common good. And we actually live with this concept of the common good all the time. I mean, we recognize the concept of the commons, which, actually was like a plot of land that sheep grazed on. And you realize that not every sheep herder, farmer can have all the grass that they want. They have to limit the number of sheep that are on the commons, or else there won't be enough grass, and then everyone will suffer. So how do we figure out? It's just the idea that we all can't have what we want at any time. And in a time of scarcity, that becomes even more clear, and that we recognize that there are limitations on individual interests in light of the good of the community. And that does involve sacrifice. Now, that term is not very political, but that's certainly what is being asked of people even now, to, stay at home and not interact with others. And that is a sacrifice that we're making for the common good right now. So decisions at the societal level should be fair and transparent and recognized as fair by those affected by them. And decisions regarding allocation, again, Dr. Ortman's going to spend a lot of time on this, should be transparent, consistent, proportional to the scale of emergency, and proportional to the scarcity. Next slide, please. So what I thought I'd do at the very end of my comments was to talk about just the ethical priorities that we normally focus on at an individual and societal level. And I want to thank a colleague, Denise Dzinski, who is at the University of Washington in Washington State, for this slide in particular that I've adapted. So what we're very used to seeing at an individual level is respect for individual autonomy, individual decision making, that we have a duty to maximize benefit to patients and minimize harm, that we have fidelity or promise keeping to the patients we take care of. We say we're going to do something, then we do it. And we recognize, even in everyday work, that not all who could benefit will receive treatment. I mean, today we have a lack of access and insurance without laying the pandemic on top of that. And then on a societal level, that we have respect for common good, and we can't focus as much or at all on individual autonomy. There's less autonomy for practitioners to make decisions about individual patients. The aim would be to maximize benefit for the greatest number of people. And I've already mentioned this about allocating resources. And then not all who could benefit receive treatment due to this scarcity. I'm going to put in a plug for one thing that I think on an individual level that nurses could do who are on this webinar that will have an impact on a societal level. Nurses are particularly situated to talk to patients and the public about advanced planning. So if nurses could talk to each patient, and probably family and friends too, regardless of diagnosis, about discussions with someone who they would trust to be their surrogate decision maker regarding their values in life-threatening situations. I think that this is a really important thing for people to have thought of today, if they have not before, so that if they find a family member in the situation of being admitted to a hospital in a life-threatening situation, that there is at least some conversation with someone that they trust about what their values are regarding relieving pain and suffering, and even the options of, in some cases, maybe not being admitted at all, if being at home with family, with proper support from palliative care or hospice in some cases might be a decision that people would make if they knew that that was a possibility. So I'm going to end my comments there and hand it over to my colleague, Dr. Ortman.
Thank you, Dr. Haddad, and I hope you all can hear me. And I appreciate the handoff you gave. Here on this first slide, you see our standard disclaimer. These are my views and not necessarily the views of the Centers for Disease Control and Prevention. Now, what we're going to be doing here is transitioning to a public health perspective And sometimes that's very difficult for doctors and nurses because the crisis standards of care differ from normal standards of care, and it involves having a fiduciary relationship, not just to your individual patients, but to the society as a whole. And sometimes, as I mentioned, doctors find that difficult. In fact, some recommendations for making triage decisions state that if a doctor is involved in a triage decision, or if there's a case for a triage decision that involves the doctor's particular patient, he or she should recuse themselves from that judgment, just because it is so hard for doctors. Their entire ethos has been formed with this idea of concentrating on their patients and having this close bond with their patients. So that I just use that to illustrate this difference between the individual perspective and the public health perspective that involves what Dr. Haddad refers to as the common good, the greatest good, sometimes referred to as the greatest good for the greatest number. And so she also mentioned the idea of interdependence, solidarity, and what we might call relational autonomy. The idea that, yes, you're an individual and you make individual decisions, but it's always in the context of social relations. And I think when you're doing public health, that notion of the social relations and the social good is always paramount. Now, I gave a version of this talk actually twice, a couple weeks ago to folks at CDC and then last week to Emory Law students. And I divided some of the public health ethics issues into 3 buckets. And one of them was avoiding stigmatizing individuals and groups. We've read stories about how Chinese Americans have been stigmatized because of this. Now, it's very important when you're doing any kind of messaging that you avoid stigmatizing groups. Also very important is the idea of liberty limiting measures such as social distancing. But we're going to focus on this 3rd bucket, allocating scarce resources, from testing for COVID-19 to ventilators to PPEs and beds and so on. And that's because I think that issue is the one that you will more likely face if you are called to the task of responding to COVID-19. Next slide, please. So there are various methods for allocating scarce resources. And I'm just going to run through these. One is the idea that every person has equal dignity. So you can not discriminate against people because of their race or their religion or their socioeconomic status. And more recently, there's been a discussion about people who have disabilities and how they are being discriminated against in receiving ventilators. And on the other hand, you shouldn't favor people who, because of their socioeconomic status, and enjoy a better position in society. And there's also been charges that movie stars and basketball players, to some extent, have been preferred in getting tests, and that's bad because it destroys the sense that we're all in this together. So you want to do things that express that's the solidarity of being in this together. Now, another aspect of equality is this notion of giving everyone an equal chance to get a scarce resource. And so some have proposed a lottery system that's sort of random, that might be hard to actually pull off if you haven't thought about that ahead of time. And another one that's listed or considered equal chance is just first come, first served. And the problem with that one is, even though it seems equal, it's going to end up favoring those who live close to the hospital or even have the resources to get to a hospital. The next one is called prioritizing the worst off or the worse off, and they can be the sickest, the most vulnerable. or in the case of this virus, older people, uh, people with diabetes, people with heart conditions. The next method is utilitarianism. Remember, that's the greatest good for the greatest number, so you're trying to maximize the benefits. And you can look at that maximizing either in terms of most lives saved, or sometimes people say most quality life years saved. So if you had a choice between saving someone who was 20 versus saving someone who was 80, you would opt for the person who was 20 because you would save 60, at least, 60 more life years than the person who's 80. But some people think that that violates the principle of equal dignity. The next method is promoting social usefulness. And that is, there are certain people who have an instrumental value in the response. And that there could be nurses, doctors, first responders, but also police and grocery people who are working in grocery stores now face a greater risk. And one of the rationales that is often put forth here is this notion of reciprocity. And that just means recompensing someone who is, who has done something to assist or has put themselves in harm's way or has in some ways been placed in a disadvantageous situation as a result of responding. So you compensate them for that service. And most people who look into this realize that some combination strategy may be the best approach. And that because one size doesn't fit all, you often have to do it in the context of your particular institution. And Dr. Haddad mentioned that, I guess I talked a little bit with her before, or maybe she mentioned that in her talk, that different hospitals can sometimes have a completely different approach, and things can be completely different in two hospitals that may not be that far apart. And it's because they perhaps have different institutional values. They may serve different kinds of populations. So we do believe that you have to have some flexibility in your approach. And so sometimes a combination strategy of one or more of these methods that I've mentioned will end up being best. Next slide, please. Now, a couple of weeks ago, I was asked to review a document at CDC that was talking about how the national stockpile should allocate resources to the various states. And one of the points that was made was that one should try to achieve equity in allocating these resources and efficiency. And they said it in a very, matter of fact, what I thought was almost a glib way, as though that was an easy thing to do. And so I disabused them of that notion and said that this is actually very hard to do. And if you don't do advanced planning, it's virtually impossible. And I'll explain why that is the case. Now, equity involves a fair distribution of resources, and fairness differs from a mathematically equal distribution. If I had 100 ventilators and 10 different people 10 different groups who wanted them, you might say an equal distribution would be to give 10 to each of them. But would that be fair? Well, if one group was in the throes of the response and another one had not yet been impacted that much, then it really wouldn't be fair, because you wouldn't be proportioning the distribution in relation to your total supply and the need that existed for it. So equity is going to be a calculus that involves a group, and it's going to have to proportion the amount that is given to each in relationship to need and supply. And one of the problems is how you can fairly distribute the burden and benefit among different groups. it often works out that, what if it's easy to get the resources to a hospital that's very close to the place where the stockpile is? They're going to tend to get favored, whereas a hospital that's in a remote area may not easy, it might be hard to get it to them. So you have to sometimes make advance preparations to make sure people living in remote areas or in vulnerable, or vulnerable populations are taken into account, because they're often the people who are most difficult to get to the hospital, for example. Now, but the major problem here, and this I consider a real dilemma. By a real dilemma, I mean that doing what you need to solve one leg of the dilemma actually uh, disadvantages the other leg, and vice versa. And I think there is a genuine dilemma here between equity and utility. And let me explain why. Uh, we know that people, vulnerable populations, minorities, African Americans, Native Americans, we know from statistics that they have, in general, worse health than majority populations. And so if you at the hospital are trying to make a decision, for example, about who might get a ventilator, and you're basing it on, their chances of survival, those people from vulnerable populations are probably going to come in with more comorbidities, more, heart disease, more diabetes. And so even though it may look like you're basing it on purely objective scientific criteria, then the outcome of that is going to be that fewer African Americans would be given ventilators than people from the majority population. Even though you never intended to be unfair, it's going to end up that your distribution is going to burden, vulnerable groups more than and benefit, say, majority populations more. And there's been a robust discussion recently in the New York Times and in the Hastings Center reports about this same problem with respect to people who have disabilities, because people with disabilities also have many more comorbidities. And so if in some ways you don't take that or try to take that into account in advance, then it's going to be virtually impossible to deal with this in the heat of the crisis. And so one of the lessons that we always preach at CDC and in public health in general is the idea of preparing and having advanced guidance. Dr. Haddad mentioned how nurses are very good at perhaps offering counseling to individuals about having an advanced directive for anybody who goes into the hospital. Why is that a good idea? It's because you have a framework for making a decision that puts you into, sort of gives you a head start, and it's already been thought through in many cases beforehand, because these decisions are so fraught in the heat of the crisis that it's very hard to see your way through. So we do believe it's very important in thinking about balancing equity and efficiency to have some advanced guidance and community input. Now, if you haven't done that ahead of time, then it's going to be very difficult, and you might just have to accept that. And you might also have to realize that it's important for your particular community or your particular hospital to do that, because you may have a different culture, you may have a different population than another hospital. And so some of the things that are more important for your population may not be as important for another population. Well, I'll leave it at that, and let's move to the next slide. I thought I'd also take a look at this idea of promoting social usefulness and instrumental value, because I think it applies uh, to nurses and to doctors. And so, and thinking about prioritizing testing, for example, I think it's pretty clear that healthcare workers and first responders should be prioritized, because if either of them has the disease it could impact many other people. You could spread it to many other people. But that same logic then would seem to apply to people, anybody who frequently interacts with the public. And that can include the people at Walmart, the people in the grocery store, policemen. So should they also be prioritized for testing? And again, when you think like that, you're thinking not only in terms of instrumental value, but you're thinking in terms of maximizing benefit. Because if these people uh, are infected, they can infect many other people. And so if you don't get them out from working with the public, many more people will be impacted. What about prioritizing ventilators for healthcare workers? Now, normally when we think about a response and think about whether whatever workers who are involved in that response, whether they should be prioritized for some service or good, we ask, well, would they recover if they got this assistance in time to be of further use to the response? And if the answer is no, then the sort of the accepted view is they don't get prioritized. But there's also another issue beyond just instrumental value, and that is this notion of reciprocity, of compensating someone for their service, especially if that service is beyond the call of duty. So that raises the question of whether we owe people something extra for when they are just engaged in their professional duty. And we've heard many nurses and many doctors on TV saying, this is just what I bargained for when I got onto this profession. And I hear that, but I also hear and see that some of these people are doing what I would call duty beyond their professional duty. They're risking their lives. They're working 13 hours, 7 days a week, and they're putting their own families in harm's way. So this is my personal opinion on that. I think that for those reasons, we should perhaps consider prioritizing ventilators for any healthcare worker who fell sick, and for two reasons. One, it would boost their morale knowing that, but we're also faced with a situation throughout the country where cities like New York are asking for volunteers from the outside. And so I think that might encourage some from the outside to volunteer if they knew that their sacrifice was being acknowledged by prioritizing them for ventilators. All right, next slide, please. And we can discuss that issue, and people can comment on that if they want. Now, one of the first things that I heard from someone in our own emergency operations center, one of the first meetings I went to for that, the speaker said, for every emergency, you need, before it happens, to have developed a plan, a rigorous plan of what everyone's going to do. The second point he said was, as soon as the response starts, that plan is obsolete. And it's obsolete because almost every response has some unique features to it. And so you have to be flexible. You have to adapt. You can't just, follow, blindly follow a prescription that was developed for a situation that may not be the one you're facing. So I've just thrown out some things here that I think are unique about COVID-19. First of all, are the novel and unknown features of the virus itself. We don't have a treatment for it. We don't know exactly how it's spread. We don't know exactly how far away you need to be. We don't know if people who have gotten the disease and recovered, how long they remain, incapable of getting the disease. Just so many unknowns. It's also exposed flaws in our healthcare system. We have a lot of people who don't have health insurance, and that problematizes their willingness or ability to get care or to be tested. I think some of that's been resolved. It also is exposing gaps in our social safety net. Look at all those millions of people who have been thrown out of a job and now can't even get through the lines to claim unemployment. I read a statistic somewhere that said some very high percentage of the American population would have a hard time dealing with any financial emergency greater than $500. this is going to put a lot of those people into a state of economic desperation. It's also exacerbating political divisions because of the intensity of this, while at the same time evoking very touching uh, uh, incidents of solidarity. We see both of those kind of things on the news. And an encouraging note regarding solidarity, we see that it's rallying global innovative research endeavors, and international researchers are applying methods that are very new, involve genetics, and they're sharing that information. And then finally, I think what, at least of all the um, disaster responses I participated in, the characteristic that seems to me most unique about this one is that it's simultaneously a massive pandemic with health consequences while also being a global economic disruptor. And that sort of perfect storm of those two together is really putting us into uncharted territories about how to deal with it. And so we see this in the news. Some people who are more worried about the economic disruption are sort of underplaying the pandemic. And I'll just end on one word about that. There's evidence that suggests that in the 1918 Spanish flu, those cities in America that took the public health uh, uh, prevention measures seriously not only had fewer cases of the disease, fewer people died, but they much more quickly rebounded from the economic effects, whereas those cities that did not do that had both more deaths and recovered much more slowly from the consequences of the disease. So that at least gives us hope that doing the right thing from a public health and medical perspective is also the right thing to do economically. Okay, next slide. And here I've just, I'm not going to talk much about this. This is just a ventilator allocation strategy we developed many years ago. It's not specific to COVID-19, but most of the ones that are coming out are based on ones that have been developed earlier. That's why I think in so many cases they've been able to come out with them quickly. And next slide, please. There's also a reference to a more specific ethical responses to the coronavirus by the Hastings Center resources. And on that, I'll end and hope to hear your questions.
I do have a question for you. Whose responsibility is it to allocate those resources at the state, community, and organizational level?
Well, I think each level has specific responsibilities. And one of the things I mentioned on one of my slides was that this is exposing gaps and flaws in our healthcare system. And one of the things I would say is we in America don't have a healthcare system per se. We have a healthcare structure, but that structure is decentralized. Um, it's actually the responsibility of states to take care of health, and each state does it independently in a different way. Some state health systems or public health systems are organized uh, hierarchically, and others are completely decentralized. And I think the same is true of hospitals. I know there's increasing consolidation of hospital care systems within our country, but we don't really have a system. And so, there are certain things that can happen if an emergency is declared, but those things are not really worked out in great detail. I know we have a national stockpile, and there is a commission, or there's a committee that makes those decisions. But I think what often happens in these kind of situations, especially if there are novel aspects to it, all these arrangements have to be worked out on the fly. And when they're worked out on the fly like that, there's often a lot of snafus, and I think we're seeing some of that as well.
This is Amy. I'll add to that. There's an article by Larry Gostin, Gostin, that you can retrieve from the Hastings Center site. It was written just, I think, this last week, and it has a really good section about the legal structure in the United States of where authority is for certain kind of decisions from the county to the state to the federal level, because a lot of things that seem confusing about this, at least on my part, was really a lack of understanding about where authority lies with these different types of decision. In that particular article, it's Gostin and then another author. But if you go to the Hastings Center site, you can find it there. And I found it very, very helpful to explain some of that.
I would echo that, and I would say that article by Larry Goss, and he's often considered the rock star of public health ethics and legal ethics, is probably the best sort of non-technical article I've seen written on this response. And one of the things that people don't understand is we have a federal system. If there's an outbreak of some disease in Arkansas, the CDC cannot just go in there and barge in there and say we're going to investigate. And it's because in our federal system, the states are the ones who have control of health concerns. CDC actually has to get invited in to conduct that investigation. And many times a large health department like New York City or Detroit will say, sorry, feds, we don't need your help. We can handle it ourselves and we don't want you butting in. But in many cases, smaller health departments will welcome CDC in, but CDC has to be invited in because we, even though we're the feds, we don't have authority to go in. And so that's some of the things that I think Dr. Haddad was mentioning that Larry Gostin clarifies.
Be sure to submit your questions. I have another one. Is it too late in the pandemic to be coordinating community input?
I think it depends on your community where it is. If it's New York City, it's probably too late. You can't do that in the middle of the outbreak. But there might be many. I think there are still many places in the country that have not yet really truly been hit. And I think if that is the case, I think it might be possible. And you'd have to probably want to do it virtually. I would not recommend, and probably would go against recommendations to do that in some sort of community forum where a lot of people were gathering. But if it were possible to do that in some kind of virtual format or a webinar, it's perhaps still possible to do that.
Guidelines have been set for the public to follow to decrease the spread of the disease. How do we get the public to realize the importance of following these guidelines to ensure their safety as well as ours?
Well, I think first of all, we need to be as clear, we use as clear language as possible. And I find myself struggling with explaining to people. Here in Omaha, I'm in Omaha, Nebraska. And it has not, certainly we have cases, we've had deaths in the state, largely in the county that Omaha is in because it has the highest population. But I find myself struggling with explaining why we need to be so strict about it when it hasn't seemed to be as bad here yet. And saying that, well, it will be because these are the things that we know. It's hard to get that message across. That we're doing things now that hopefully will keep the levels low here because we didn't have as many initial cases. And so to try and explain public health and disease spread with an illness that we still can't identify by just looking at someone. I think that part of it, I think if more testing were to be done and we had a better idea of the percentage of the population at any one time that might have the disease and be asymptomatic, I think that would be a stronger argument to people to encourage them to continue to stay at social distance or at home as much as possible, if that's possible, and to help support programs that help people for whom that is very difficult to do because they work in one of these areas where they need to be working to continue to bring home a paycheck, or where people just no longer have jobs and are frustrated with having to stay at home and wanting the restrictions on the working and gaining an income and all that, they want them to be lifted because it doesn't appear apparent that right now that there's problems in the local community. I think all of those things have to go together, and they have to come from someone who's trusted. I mean, is it the governor of the state that does this? Is it the mayor? Is it the head of the health department? Sometimes people don't even know who's head of their health department, so I don't know that they would necessarily respect the position coming from that role. So I think careful consideration of who gives the message, clear language, and some way for people to see that the role that they play has implications for their future. Because I personally don't want to just count on solidarity.
Right.
I'd like to think it was there, but I just don't think I can count on it. So I think we have to bring it back to, if this is sacrifice is you're making now, you will see. And you know what? We can't really say that because we just don't know yet if this disease is going to, hit its peak and then go away, or hit a peak and then hit another peak in the fall, or if people can get it even after they've had it. I mean, there's just still so many unknowns, and that makes it hard to give a consistent message.
Yeah, I really want to echo that last point. There are so many unknowns, and the lines of of who should be doing what are not firmly enough established. That this particular incident is putting pressure on all of those gaps and our lack of information. But one thing I would say is this, that this is a challenge that people in public health are very, very familiar with. The idea of prevention. If there's when things aren't there, it's very hard to try to persuade people to do something that when they can't see the concern that is motivating you. We see that with vaccines. When before the vaccines were introduced, and there were many cases of measles and polio, and then everyone was afraid of them. People lined up when the polio vaccine first came out. You didn't need to do anything to motivate them. They saw before their very eyes the impact of polio. But after the very success of all these measures, then then people didn't have experience of measles or polio, and so it became very difficult. There's now a lot of people who are vaccine hesitant, and it's in part because they've never seen these things, and they know that there can sometimes be adverse reactions, and so that's more paramount in their mind. So similarly here, as Dr. Haddad mentioned, if no one sees it in their community, it's very hard to convince people. And one of the things I'm trying to emphasize is this notion of a precautionary approach. And a precautionary approach sounds like it's something that's very hesitant or laid back, but the name is misleading, because a precautionary approach is actually a proactive, preemptory kind of approach that boldly preempts full evidence coming in, and says there's enough evidence of a coming danger to warrant that if we don't do something ahead of the curve, we're going to be in trouble. So out of an abundance of caution, even before it happens, we need to be proactive and get out ahead of it. And people have talked about bending the curve. If you wait until the evidence is palpable, it's too late. And I think what you have to emphasize to people is look at what has happened to New York and other countries that waited until the evidence was in. If you wait until the evidence is in on this disease, you're going to be in the same situation as New York. So you have to get out in front. So the precautionary approach is the opposite of being hesitant and cautious. It's being proactive and aggressive in getting out ahead of this curve that you hear talk about.
What can nurses do to advocate for support and resources for their state or their city in order to get that relief?
Well,
It's hard to say. I'm just gonna. I'll be brief. I saw some pictures on TV of the nurses outside who were, who were at wits' end. They were outside in the street with placards to make their case. That's for people who are already in that desperate situation.
yeah, and for those that aren't in the desperate situation yet, I mean, we have nursing associations in all of our states, as far as I know, specialty and general. And I think that this is a time for nursing organizations to step up and speak with a united voice about what they can contribute to the planning, to be at the table. And everybody uses that metaphor constantly, but as I grow older, I can see how much more important it was than I did when I was younger. If you don't have a place at the table to speak to what you can contribute and what your concerns are, no one is going to bring those forward. So to work collectively as a profession to get people present at decisions, I think is just critical. So I would recommend linking arms with other nurses within organizations or other ways. But I would promote within professional associations, because there's already this structure, and to try and use those as a vehicle to speak with the voice of numbers rather than just individuals trying to tackle this themselves.
Yeah.
How can long-term care facilities advocate to receive much-needed PPE as well?
Well,
Well, I
again,
mean, yeah. Go ahead, Amy.
you go ahead. I was just going to
I
say
was just
that.
gonna.
Go
Yeah.
on.
There is something that's called an appeal to pity, and I don't mean to use that term dismissively, but they're in a bad way, because almost their entire population is consists of people who have a special susceptibility to it. So I think they just have to dramatize the plight they're in, and hope that people recognize the direness of their situation. But again, Amy,
Well,
what do you think?
it's state level again. So see, that's a state level thing. Though CMS has guidelines that they keep updating for, or guidance for what long-term care facilities should be doing. And now it's almost like a black box, because individual family members aren't going to be able to be in there to see what is happening. So you have to rely on administrators of skilled care facilities who are monitored at the state level. So it addressing it again is like appealing for supplies is only part of the problem. You want them to follow all of the guidelines that CMS has put out there. And they're pretty basic, but it's going to take a concerted effort on leadership in skilled care facilities that I think are generally held by registered nurses and a lot of other individuals who provide care. Um, and being kind of a watchdog with that. There's state associations for assisted skilled care facilities too that are, being really scrutinized right now to be able to keep up their standards. And it's all the things that you would expect. I mean, their residents have to stay in their rooms. They want to have different staff with different populations. They may have to turn some into totally only patients who have the diagnosis. I mean, all of those things are in guidance for that, but it occurs at a state level. So you would have to be, and I'll tell you something, in my experience in Nebraska, at least, the state level that monitors and regulates skilled care facilities are pretty much in there all the time to make sure that there are no abuses and neglect going on. And so I imagine it's with heightened awareness that they are monitoring what's happening in skilled care facilities at the state level.
Yeah, I would just add one thing here, that you probably heard the expression "the fog of war," but the guy who invented that also talked about the friction of war,
Mm.
and that is that, in these kind of crises, everything becomes 10 times harder. And when you're trying to do this for the first time, the lines of communication aren't there. I remember when we first started working with the Emergency Operations Center at CDC, and we'd do drills or something, we'd be involved in a disaster response. One of the hardest things was to just get lines of communication established between CDC and even a place like the FDA. In an emergency, you just can't call up the FDA. You know,
Mm-hmm.
it's like, who do you need? Who do you send to? And so it's kind of like, I don't know if you've ever seen a rock group when they're setting up their equipment before a big concert. There's thousands of wires, and they have to link them thousands of things to the right connections to make it work. And you almost have to do that prior to this happening. And one of the problems I'm seeing with COVID-19 is this has put such enormous novel stress on our system that these lines of communication have not, in many cases, been set up for some of the novelties that are involved. And so, yes, it would be good for the nurses to organize and, but if they haven't done that, if those organizations aren't in place, it's going to be very difficult to do it now. So sometimes what I have to say, as hard as this sounds, start preparing for the next emergency in a way.
Mm-hmm.
Think about what you would do had you had time to do something like this ahead of time, because
Sure.
in many cases it's too late because of this friction and fog of war. I know that's not a positive. I wanted to say that in a way that is positive, uh, um, and be thinking of the future, because we will come out of this, but we will need to prepare. And oftentimes, what happens as soon as we get over this, then people go back to their old ways of saying, okay, problem not present, let's just forget about it. No, that's precisely the time to strike while the iron is hot, while people have this still fresh in their mind. And if you can have a plan ready to go right then when people are scrambling to assess what happened, I think it stands a much better chance of being implemented then.
I agree.
I agree prioritizing ventilators for healthcare workers would recognize their sacrifice. How do we get that message into practice settings?
Well, you you talk about it, you mention it to the people and if you are one of the ones who get to participate in one of these ethical decision making, you pipe up and mention that. I mean, um, part of what I'm doing here is trying to make that point to people who may have some say in the decision. So spread the word. I've said this, at the in the sort of courses and seminars I've given. So keep spreading the word. I mean, that's not the best way. I mean, I wish I had more impact, but if you know journalists, spread the word.
I've heard from some nurse colleagues around the country who are involved in ethics, but also interested in how to get that message out about what the nurse's role is and the kinds of sacrifices, and what skills they bring to all of this, to just get the word out in their local community, like in their local newspaper or their local news, and start at that level. So, um, and a lot of people have been successful with that. And that might be something that, in a community that has a lot of hospitals or a lot of competition among healthcare institutions, maybe the person in marketing at the hospital that you work at would have some ideas about how to get the word out about what the nurses are doing or other providers of care. I mean, anything to get out a positive message of what staff are doing during this time, I think is good for everybody. It reassures the public, and it also gets the message out about the kind of work that is being contributed.
Right, and we're seeing on TV almost every night, we're seeing these expressions of thankfulness, by people in New York as as people walk home from hospitals that have spent all day fighting for people's lives. I think those same people who are cheering them on, I don't think it would be a hard sell to persuade them that these people they see walking below them who are going to have to, possibly risk infecting their families, that those people don't deserve more than just thank you for your service, that
Yeah.
they've earned a ventilator should they fall sick.
Thank you so much to our presenters today for all this great information. Sigma is grateful that you took the time to share with this audience and look forward to hearing more from you in the future. As a reminder to the attendees, can you please submit the state or country you live in? And thank you to our attendees for joining us. Have a good afternoon.
Thank you.
Yeah, thank you for the opportunity to address your group.
Bye.
So long. Stay safe.